Good evening. My name is Dr. Raymond Wu. I'm here to spend some time talking to you a little bit about scoliosis. Hopefully I can do this in much less than an hour. First of all, I want to talk about what's scoliosis. Scoliosis, everybody thinks about it as primarily being something which you see when you're looking at somebody head-on. But really, what you see is in head-on view is just the tip of the iceberg. It's really a three-dimensional problem. Not only do you see the apparent medial deviation from the midline when you look at a person head-on, but there's also a flattening of the normal contours of the back, so you'll see a loss of the apparent normal sway back in the lower spine, as well as a loss of the normal contour in the upper spine. More importantly, there's also a rotational component, which you'll see in terms of the ribs being lifted up on one side of the spine. And this is what's being checked when the kids are being screened for scoliosis at school. To be really called normal scoliosis or idiopathic scoliosis, you really have to be sure there's no other reason why there is a cause for a curve. To be called scoliosis, the curve has got to be more than 10 degrees. And when we talk about scoliosis, we talk about it in terms of degrees, not percentages, but degrees. And you can describe curves based upon three things. One is the size of the curve, where the curve is at, where the convexity or where the most curved portion of the back curve is at, and in terms of the pattern. So, for example, anything less than 10 degrees, which is a scoliosis curve, is technically not even called scoliosis because anything less than 10 degrees is within normal limits. So, if somebody has a 10-degree curve or smaller, that's considered relatively normal, and you don't have to worry too much about it. It's the curves which are more than 10 degrees which are formally called scoliosis. So you can talk about curves as being left or right, thoracic or lumbar. And in this example you see on the screen, the upper curve is in the thoracic spine, so we'll call it a thoracic curve. And the lower curve is in the lumbar spine, and that's a lumbar curve. Or you can talk about these curves as being a right curve, because the thoracic curve points towards the right side of the body. And the lumbar curve is mentioned as a left curve because the apex of the lumbar spine goes towards the left side of the body. Alternately, you can say that this curve is a double curve or a double major curve. All those things are all the same, but there are various ways you can use to describe scoliosis. To be called really normal scoliosis or idiopathic scoliosis, you have to be sure that there's no other reason why you can cause the back to curve. So this discussion is not about all the other causes of scoliosis, such as congenital birth defects, where a kid is not born with a normal back. We're not talking about conditions such as polio, cerebral palsy, or muscular dystrophy, where you can have a curvature with these conditions. Scoliosis, it really isn't talked about in terms of people who've got a curve in their back because of a ruptured disc or a pulled muscle. We don't really talk about scoliosis if it's due to a problem due to a short leg either. All of these conditions can cause a curve, but aren't really called scoliosis when you start talking about the curves themselves. To be truly adolescent idiopathic scoliosis, by that I'm talking about it's a curve with no other apparent cause in a child older than age 10. There has to be no history of an injury. There shouldn't be a problem with a leg being longer than the other, and there shouldn't really be anything else wrong with a child. One of the biggest problems is that there shouldn't be any pain. It's okay to have back pain and scoliosis, but if you've got terrible scoliosis with excruciating back pain, that's a big warning sign that perhaps this is not normal scoliosis. And this is something which you should talk to your doctor about. Also, to be called adolescent, your child has to be older than age 10, and anything less than that is called infantile or early onset. So, when does this occur? Well, it really occurs in all age groups. And you see in the slide there that those children who have curves in ages less than 4, they're called infantile scoliosis. And those children with a curve of 11 years or more, that's a more common adolescent scoliosis. And then between ages 4 and 10, these are called juvenile or early onset scoliosis. But whatever the cause is, the younger the age where the scoliosis begins to occur, the more time there is for the curve to get worse. So by and large, the earlier your child is diagnosed with scoliosis, the more aggressive it's going to be because the more potential growth there is and the more time there is for the curve to worsen. And with that, it's more likely that treatment's necessary. If you take a look at scoliosis, and all the kids who are seen with a curve that's more than 10 degrees is actually quite common. Almost 2 to 3 of every 100 children have got some kind of curve that's more than 10 degrees. But if you take a look at those curves, which are larger and larger and larger, including those curves which are more than 40 degrees, you can see that there's a very small percentage of children who actually have this problem. Less than 1% of all children have a curve of more than 40 degrees. So, what does this mean? What it means is that scoliosis is pretty darn common, especially the small curves. It also means that most of the small curves stay small, and not a lot of them get larger, and that must mean that most of these curves do well without any treatment at all. So, well, what do you do about the other kids? People know that scoliosis is not about what you carry on your back, what exercises you don't do, or how you wear your shoes, or what sports you play. It's nothing to do with that. It's all basically hereditary. It is all genetically driven. The best way to think about this is how some children may need to wear glasses for their eyes or braces for their teeth. It's not because they did something wrong or they're not doing something correctly, but it's probably because their parents either had to wear braces for their teeth or wearing glasses for poor eyesight. The same thing should be thought about for scoliosis. In terms of genetics, it's most often autosomal dominant. What that means is that it's usually found in every generation. Now, just because a parent doesn't have a bad back doesn't necessarily mean that they can't have scoliosis. In fact, a lot of adults who get an x-ray for another reason usually are surprised to find that they have a small curve in their back. But suffice to say, if you have a daughter with scoliosis, the chances are that your younger child is going to have 50% chance, more likelihood of having scoliosis. And in fact, the more difficult and more progressive curves happen in girls. If we take a look at the next slide, you'll find that in terms of the small curves, there's really no difference between boys and girls in terms of the prevalence of scoliosis. But if you take a look at the larger curves, the ones which actually require treatment, there's almost a 4-to-1 ratio of boys to girls. So, what if you do nothing at all? Well, people do know that as a child grows, the curves do get worse. But they're supposed to stop when a child's done growing. As a general rule, at maturity, the curves should stop if they're small. The only problem is if the curves are too large. And as a general guideline, if the curve in the thoracic spine, or this area of the spine where the rib cage is at, if it's more than 50 degrees by the time the child's done growing, it's probably going to continue to get worse. In the lumbar spine, that number is somewhat lower, primarily because of the lack of stabilizing factors because there's no rib cage. That number is about 30 degrees. So if the child reaches maturity and the curve in that location is larger than those two numbers, it's likely not to stop. And as an adult, it's likely to continue to get worse at a rate of about 1 degree a year. The smaller curves, which are less than 30 degrees, generally don't progress at all after maturity. So, why do you want to treat scoliosis? Well, that's a good question. A lot of people say, well, I don't want my child to be disabled. And that's a good concern, but if you take a look at the data out in the literature, the problems with back pain and disability aren't really a problem until the curves are very large, almost 50 to 100 degrees. And even then, it's not really a problem until the people are in their 4th decade of life. Another concern that some people ask is maybe the scoliosis is going to cause problems with heart function or the ability of my child's lungs to expand, and maybe he'll have problems with breathing. That's also true. And in fact, with curves more than 50 degrees or so, there can be a loss of lung function of about 23%. But really, there's so much reserve built into your lung and heart function that you really seldom use all of the capacity that those organs have. So you really don't have many problems at all until your curves are large. People say there's not really a big problem with pulmonary function until your curve's almost 100 degrees, and that's a lot. Another third reason why people are concerned is maybe they're concerned that having scoliosis is going to preclude having a normal pregnancy. Well, as people know now, you can have a normal pregnancy and delivery with scoliosis, and pregnancy is not going to make it any worse. If you think about it, a real reason why people are concerned about scoliosis is because they're concerned about the appearance and the well-being of their child. It's a normal reaction as a parent. You want the best for your child. You want a child to grow up and attract a suitable, attractive male or female spouse, have a nice family, have a well-paying job, and be prosperous. Wouldn't that be the best if they didn't have something disfiguring their back? So if you think about it, maybe the real reason why we're concerned about scoliosis is for psychosocial reasons. So the treatment philosophy for scoliosis should be in aiming to keep the thoracic curves at less than 50 degrees and the lumbar curves less than 30 degrees. My philosophy is that no children should enter adult life with a curve of more than 50 degrees. And those are children who we should try to get fixed surgically. Okay, so now your child has been told they've got scoliosis. Now what? Well, the next step is to get a set of x-rays. And to be accurate, the diagnostic set of x-rays which you need to get are going to be long x-rays of their entire spine from their chin to their pelvis. This requires some special equipment, and most doctors' offices and most outpatient radiology offices aren't equipped to take these x-rays. But the diagnostic x-ray is a long x-ray from the chin to the pelvis with a child standing with their back away from the board and they're facing away from the x-ray machine, and you want to be able to see everything. Now if you take a look at the pictures on the screen, you see an old picture of a child with their face pointing towards the camera or the x-ray machine. That's the way these x-rays used to be taken, maybe in the 60s and 70s or so. You can see that this child has had to have its breast shielded. And that's because they're concerned for breast cancer. And indeed, 30 years ago, when people used to take x-rays with a child facing the x-ray machine, there was a concern about breast cancer. But now with digital x-ray, the fact that we turn the children away from the x-ray machine, there's no longer a concern about breast cancer because the muscle and the lung structure blocks radiation from harming the breast tissue. And now we use lower doses of x-ray radiation, so the child should be turned away from the x-ray camera. When the x-rays are taken, they're read by a radiologist. And the way that they're supposed to be read is using what's called the Cobb method. And then after that, there is a method of trying to assess how mature your child's bones are. A very convenient way of measuring this is looking at the appearance of the growth plate that normally rims the top of the pelvis. And this is called the apophysis or the pelvic apophysis. And people talk about the formation or the presence of this based upon quarters. And this has been called the Risser system or the Risser classification. It's broken down from 1 to 4. And when the growth plate's fully formed, until it caps the pelvis, the child's assumed to be done growing. So here in this example, you see an x-ray. You can see on top of the pelvis, there's a very small eyebrow of bone on the top of the pelvis. And this shows that the very first quarter of the growth plates begin to appear. The child would be a Risser 1 and is relatively immature. When these are measured, they're traditionally measured with a ruler, such as this. And still, even though we have digital x-rays, a lot of radiologists still use a ruler and a pencil. It's important to know that there's lots of human error when it comes to measuring x-rays. And there's a lot of concern that parents have when they come because they feel that there's been a worsening of their curves of 2 or 3 degrees over a matter of months. It's important to remember that even in the best of situations, there's going to be some variability of measurement. It's just purely human error. And any measurement within 3 degrees of the previous one is by all standards basically the same measurement. To be truly worse, the difference has got to be more than 7 degrees. And even though people have converted now mostly to digital radiography, and we now use computerized measuring tools to measure this, the reliability and accuracy is no better than the old-fashioned way. So, what are our options? Well, there's really 3 choices. You can observe and do nothing and watch. And those really are reserved for children with curves which are small and which are likely to remain small up until skeletal maturity. You can also observe those children who've got curves which are low to begin with and watch them as they get older. The third would be those children who are relatively mature where there's not a lot of growth left in their back. Because of that, there's a relatively low risk that their back will get worse as they get older. You can also think about bracing children, and that's what most surgeons do. And bracing does work very well when used properly. There's a lot of misconception that bracing can actually straighten the curve, and that by and large is not very well documented and very seldom seen. You may get a correction of maybe 2 or 3 degrees out of the curve, but it's not really possible to be able to expect that your child's back can be braced back towards perfectly straight, simply because the child doesn't have enough growth left in their spine before they're done growing. It's possible if your child is 4 or 5 years old to have this happen, but not if your child's 10 or 11 years old. Really, the goal of bracing is to halt progression of the curve, and it does do so about 75% of the time. The third is surgical fusion, and that does halt progression of the curve because of the mechanical constriction that the rods do in correcting the spine, and it corrects the curve as well. Well, what's the risk of this progressing in your child? It really kind of depends on 2 things. It depends upon their skeletal maturity and the size of the curve the first time it was detected. In terms of skeletal maturity, there are a lot of different ways of trying to get a handle on how mature your child's skeleton is. You can talk about their calendar age, which is the most common way of talking about maturity. But as you know, there are always some examples where children are late bloomers or children may be early bloomers. So you can't really say that one 12-year-old is the same as another 12-year-old. For girls, it's easy to say when children are mature because you can ask them when their first menstrual period is. And that's a very easy thing to ask, especially since most cases of bad scoliosis occur in girls. So the onset of menstrual periods is what we usually ask children to see whether or not they are relatively skeletally mature. You could also look at evidence of secondary sexual changes, such as muscle development, breast development, armpit hair, facial hair, etc. Those are relatively good, but then again, some children are different than others, and some simply just don't have a lot of facial hair. The third would be the Risser sign and the development of those growth plates we talked about earlier on the x-ray. Of the 4 things that we talked about, perhaps menstrual periods and the x-ray probably are the most important. In terms of the curve size at the time that the child's first diagnosed, it's safe to say that if a child's diagnosed with a curve that's already large, they're at a higher risk of getting worse. And if the child is seen with a small curve, they're at a lower risk. This next slide is a great slide because it summarizes a lot of these concepts in one slide. This is about girls, and it shows the different things which we're looking at. We try to talk about the relative risk that the scoliosis is going to get worse. And we think about things such as the onset of the first menstrual period, armpit hair, breast development, and then the growth plates, the Risser grade, or the ring apophysis fusion. Those are all findings which each of them have their own variability in terms of how early they change and what variability each person has in terms of expressing those changes. So each of those characteristics has its own bell-shaped curve, as you can see. You can see that some of those bell-shaped curves are very broad and some are very narrow. And if you look at the one which is the most narrow, it's the onset of your first menstrual period. The onset of first menstrual period ranges from about 11.4 years of age to 14.5 years of age. And the average girl has the onset of the menstrual period at age 13. It's important to see that because the top marker is called spinal growth velocity. And that's what we're really concerned about. Because as a child grows, it's the growth of the spine that's important. And the faster the spine grows, the higher the risk that the curve is going to get worse. If you see, even that in and of itself has its own bell-shaped distribution. And you can see that the time that the child's growing the fastest in the back is at 11.97 years. So if you take a look at all the physical characteristics of skeletal maturity, such as breast development, pubic hair, axillary hair, and menstrual periods, the only thing that really correlates best with the child's fastest rate of growth is the onset of the first menstrual period. And if the child has had their first menstrual period, it's likely that they've already passed the period of their fastest growth of their back, and therefore their risk of worsening is actually dropping as they get older. Now for boys, in this next slide, is a lot less certain because we don't have menstrual periods to look at. And in fact, if you look at all the things that we look for in boys, such as pubic hair, armpit hair, facial hair, and genital development, all of those have some very wide curves. And it's hard to know what's the best estimate. But if I were to look at this graph, I'd have to say that armpit hair or axillary hair probably correlates best with the peak spine growth velocity. Thankfully, only 1 out of every 4 children with bad scoliosis is a boy, so this is not really as much of a concern. If you were to look carefully at what the scientific literature says, people say that really it's all about maturity and about the curve size. And if a child's very mature, the risk is very low. If the child's very young, the risk is very high. And also, if the curve is very small, the risk is very low, but if the risk is larger, the curve is very high. This table talks about curve magnitude in being less than 19 or more than 19. And in terms of maturity, you talk about Risser's sign, those x-rays. Either the growth plate is not formed yet or half formed, or is it more than 50% formed? And that's stage 2 or 4. In those children who are relatively immature, with a Risser's sign 0 to 1, with a small curve, their risk for getting worse is not that high. It's about 1 out of 4. And the same thing holds true roughly for the older child with a curve that's more than 19 degrees. If you look at a child who's relatively mature with a small curve of less than 19 degrees, they've got an extremely low risk of progression of about 2%. For those children who are relatively immature with a Risser's sign of 0 to 1 and a curve of more than 19 degrees, they have the worst risk of getting worse of over 2/3. So, what does this mean? And when should my child be reevaluated? Well, people know that on the average, in a growing child, curves progress at about 1 degree a month. As an adult, or a skeletally mature child, it's 1 degree a year. If I just said that the measurement error for scoliosis measuring, it's about 3 degrees plus or minus, it'd be hard to be able to say that a change of 2 or 3 degrees really is a true change, and perhaps it's human error. You're looking for a curve of about 5 or 6 degrees worsening over a span of 5 to 6 months. So my recommendation would be, at the very worst, if you're very concerned, would be to have the x-ray repeated in 6 months. At that time, if the curve has worsened, it should worsen to a point where it's grown beyond any doubt that it's beyond measurement error. And for those children who are at relatively low risk, nothing more than an x-ray every year would be necessary for reevaluating their spine. For those children who should be braced, that's a very relatively small percentage of kids. And even though a perusal of the internet will show many websites talking about bracing, it's now been found that more and more of those children who we had braced previously probably did not really benefit from bracing or didn't even require the brace at all. So currently, only those children who are relatively immature with a Risser grade of less than 3, within a year and a half of their first menstrual period, should be considered for a brace. Also, those children who present with a large curve generally have a curve that's too large to the point where bracing can be efficacious. So the curve should be at least 25 degrees on initial presentation. Lastly, the third category would be any child with a smaller curve where you've been able to document a progression of the curve of about more than 5 or 6 degrees within 6 months. They should be considered a candidate for bracing. Who shouldn't be braced? Well, those are children who are almost done growing or who are skeletally mature. And by skeletally mature in girls, I'm talking about children who've had at least 2 years of menstrual periods. At that point, they're really done growing. For boys, probably age 16 or so. And it's important to know that the delay in terms of stopping to brace and maybe bracing a child who shouldn't be braced may result in a delay of treatment, which can cause a problem with early intervention with surgery. Which children need surgery? Well, those children who've got large curves. As we talked about, the threshold for the curves getting worse after skeletal maturity are 50 degrees in the thoracic spine and 40 degrees in the lumbar spine. So as a general guideline, I'd say those children who need surgery would be any child with a curve that's more than 50 degrees in the thoracic spine and more than 40 degrees in the lumbar spine. And that is irregardless of their age. That applies equally to children who are 10 as well as to children who are 18. So what are you supposed to be looking for when you look at your child? Well, this is an example of a child who was seen in my office with scoliosis. And I'd be looking for things like the shoulder being level or tilted. And in this example, you can see this child's shoulders are ever so slightly tilted, in that the left shoulder is a little lower than the right shoulder. Also, you like to see whether or not the head and the shoulders are centered over the pelvis, because sometimes with a bad curve, the shoulders and the chest can be shifted to the left or to the right over the hips. Also, sometimes you'll see an extra crease on the side of the chest or back, as you can see on this slide. And lastly, sometimes the shoulder blade is sticking out, such as the patient's right shoulder blade on this slide. School screening has historically had a large role in terms of detecting scoliosis. Its origins trace back almost 60 years, where kids in Delaware were screened for tuberculosis. And really, it's been endorsed since 1974 by the American Academy of Orthopedic Surgery. In fact, in 1982, John Lonstein in Minneapolis, St. Paul, documented that of the kids who were evaluated for scoliosis, 3.4% of those children tested positive and were referred for evaluation. And of those children, about half of them, or 1.2%, were confirmed to have scoliosis. It's interesting because school screening is not universal. And in many countries, they've been deemed as being not cost effective. They've been discontinued. There have been programs initiated in countries such as Ireland and Sweden, Germany, Japan, and Hong Kong. And other countries such as Great Britain have decided, even since 1983, not to screen because of some controversy in terms of the efficacy of screening programs. In the United States, however, some form of screening is done in all the states in the country. And in 21 of the 50 states, there is actually state legislation mandating some form of screening as of 2002. The recommendation from the Scoliosis Research Society is that children in grades 5 through 9 should be screened, especially those children from the 10 to 14 age group. And because girls are more likely to have scoliosis than boys, perhaps the boys should be screened less than the girls, or less frequently. To work well as a screening tool, scoliosis screening should be rapid, it should be accurate, it should be cheap and reproducible, it should be sensitive, it should be specific, and it should be a low false positive or a false negative rate. And by that, I'm talking about there should be a low amount of children who test positive for scoliosis who don't actually have a curve, and vice versa, there should be a low percentage of children who actually have a curve but who don't test positive for a screening test for scoliosis. Follow-up studies for school screening do show that if the school screening program has been well implemented, there should be a decrease in the number of children who need surgery, since the smaller curves get picked up and a lot of children can get braced. Also, the magnitude at a time of presentation should be less than in the past, because you're making a difference in terms of the percentage of kids who are picked up. And also, if it does work well, there should be less kids who are seen in a doctor's office who present with severe curves. The problem with school screening, as with scoliosis, is it was very hard to know what would happen if you did nothing at all. And that was a very difficult thing to talk to parents when faced with a situation of an 11 or 12-year-old child who has a small curve. Oftentimes, one would err towards the side of caution and recommend a long course of regular checkups where x-rays are done twice a year, and a child's asked to be seen at least once or twice a year until they're done growing. And that would result in a lot of cost and expense, not only in terms of time out of work for the parents, but also cost for x-rays and cost for transportation, as well as the subsequent risk of any kind of cancer for children who are exposed to x-ray radiation through their formative years. But up until recently, there was no way to know whether or not your child is going to be a child who would actually have a problem. Well, there's been something new that's come since 2008, and thanks to a bunch of good researchers, there's been a development for a very good gene test available called Scoliosis score. It came about through the analysis of 9,000 patients who had severe scoliosis, and their saliva was sampled to see if the genes from their skin cells in the saliva could be analyzed to see if there were any common genes that these children with severe scoliosis had. And indeed, they found 53 gene markers for scoliosis. So now this test is available where with a simple saliva sample, you can actually find out in 2 weeks whether or not your child who has a small curve may end up having severe scoliosis, mild scoliosis, or moderate scoliosis. And a score will come in a form of a score from 0 to 200, and it will give you some estimate and give you a crystal ball view with 99% accuracy as to whether or not your child will have a problem. And this has been a landmark breakthrough in terms of scoliosis because it's been able to diminish the amount of children who require treatment and avoid a lot of unnecessary visits to a doctor, as well as a lot of exposure of children to X-ray radiation. The screening test that's done at school is called the Adams forward bending test. And it's done with a careful, trained eye. And the whole idea is not to look to see if the spine is crooked, because that's terribly misleading. You're trying to see if there's a rotational problem with the back. And remember, the first slide in this discussion, I said that scoliosis is a three-dimensional problem, and the third dimension is rotation. And that's what causes the ribs to rise up, because the spine is rolling onto its side. You see it as the shoulder blade being lifted up, but when a child's being examined with the forward bending test, the child's asked to bring their hands together in front of them, and it pulls the shoulder blades out of the way so you can really see the rib cage. And the observer is trying to look to see if the ribs on one side of their chest are higher than the other, or if the muscles on the low back and the lumbar spine are higher on one side than the other. So in the same example of this child with scoliosis, you can see when she bends forward, she actually has two curves. The upper curve, or thoracic curve, is seen in the upper right-hand corner, where the rib cage on the right-hand side is higher than the left-hand side. And then as the child continues to bend forward, another more subtle elevation of the muscles of the flank of the left side is seen being more prominent and higher than the right-hand side. And this child indeed has got a double curve. The problem with the school testing and the problem with the Adams forward bending test is that it's not accurately done most of the time. And this has resulted in a lot of referrals to the pediatrician, a lot of referrals to the pediatric orthopedic surgeon of children who don't have scoliosis. And we call this scoliosis because it's more of a problem about inadequate education than anything else. The problem is that depending upon who's examining the patient and the child, you can have a very poor specificity. It may be unlikely that you can detect a child who actually has a curve, or there may be some children who don't have scoliosis who do test positive. Also, because we ask the children to bend forward, some of them who've got tight hamstrings physically can't bend forward very comfortably, and in the attempt to try to appease the doctor, they will try to lean with one hand more than the other, give you a false positive test. The third thing is that a lot of children just aren't very comfortable bending forward in front of a stranger. So there's a certain amount of cooperation which is necessary on behalf of the child. The fourth thing is that some children have got a short leg, and that will give you a false positive test. Some people may have a shorter arm, and that will give you a false positive test. And finally, there are some parents who just can't believe anything which the school nurse says. They want to be seen by a doctor just to be sure. Well, the problem is that these add a lot in terms of time spent out of school, time spent out of work, as well as healthcare dollars. For those children who have a questionable test, I propose that a modified Adams forward bending test is done. And that's done identically to what's being done with a child standing, but a child is asked to sit down. And when you do that, there are three things which occur. Number one, the child doesn't have to worry about having tight hamstrings anymore. Number two, the child feels more secure and more balanced and is not afraid of falling over when they bend forward. The child is asked to bend forward with their head between their knees and try to put their hands on the floor. That usually does a far better job than a conventional standing forward bending test. The tool that should be used to more accurately assess the curve is this. It's called a scoliometer, and this has been around since 1973. It's a very simple, cheap, effective tool, and it's used to objectively quantify the rib hump. And it's run up and down across a child's back, trying to see what the rotation is of the chest at its very, very worst. It's known that there can't be a change in the scoliosis unless there's a change in the rotation. And if there's a change in the rotation of the back, you should see it because the rib cage would be changing, and you'll see it because the scoliometer reading would be worse. The way the test is done, the child's asked to stand straight with the hands together, just like an Adams forward bending test, but the scoliometer is placed over the middle of their back. And as the child bends forward, the scoliometer is run down the middle of their back, and you're looking to see what the maximum reading is. And anything more than 5 to 7 degrees indicates the likelihood that your child has a curve and should therefore be referred to their pediatrician or an orthopedic surgeon for an x-ray. There are other ways of evaluating children for scoliosis, and one of this is called moire surface topography. This is something which is done with polarized light, where it highlights differences in the profile of the child's outline of the back. It's well proven to work well. It has been used in other countries such as England and Hong Kong. It's often very valuable to be done in conjunction with standard screening because the combination of that, combined with the scoliometer testing, has proven to be superior than any other method alone. Unfortunately, moire surface topography isn't really done in the United States. So in conclusion, there are many new genetic technologies available which have improved our ability to render a prognosis and tell whether or not your child will have a problem with their back as they get older. But there are also some very simple and effective methods which are already in use which can help improve the outcome. Lastly, there's more research that needs to be done to help provide more information and more data to help guide future decision making. I want to thank you for taking the time to listen and to read. I hope that you have questions, and if you do, please feel free to contact us at our website. I'll be happy to answer any of your questions. Thank you.